Chapter 20. This chapter is going to cover our blood disorders in pediatrics, as well as some immune disorders or diseases, and also cancer, which it refers to as neoplastic disorders. So you can look at the objectives to kind of see what we're going to be focusing on. And I've already divided the PowerPoint into parts so that you're kind of learning the blood and immune content first, and then transitioning into the neoplastic or cancer content. And some information may be duplicated. For example, hematopoietic stem cell transplantation, that's something that's talked about in the chapter, both in terms of the blood disorders and immune disorders, as well as in the cancer content. So you may see some, expansion of that information in different places. Okay, so the disorders that we're going to focus on in terms of bleeding are going to include iron deficiency anemia, which I'm hoping you've seen previously in MedSurg as well as in Patho. So we're going to, kind of be reviewing, giving a little bit more insight to how it pertains to children, but a lot of it should be a refresher. Same is true for sickle cell, hemophilia, and then the last one you may not have heard of before is called von Willebrand disease. It manifests very similarly to hemophilia, but there are some important differences with that. Just some terminology you may want to review to kind of help you better understand what's going on pathophysiologically would be hematopoiesis, which is the process through which bone marrow is actually producing blood cells and platelets, versus erythropoiesis, which is the production of red blood cells that includes erythropoietin and iron. So basically a hematologic disorder is occurring when there's some kind of disruption to one of these processes. Okay, so starting with iron deficiency anemia, we've talked about this already in class when we were talking about the growth and development phases, because we discussed how in infants this is something that we have to watch for with children, especially because they transition from mostly having breast milk or formula to then going to solid foods, and that transition happens when the child's able to make that transition, as far as like the extrusion reflex has disappeared, their GI system can handle the changes in what their food content's going to be. But it's also happening because any maternal stores of iron that they've received from the mom have been used. So now we have to make sure that we're giving them iron fortified cereals and foods or solids that have iron in them so that they can avoid ending up in this anemic state. So iron deficiency anemia, basically there's not enough of the healthy red blood cells that are needed for carrying oxygen to the tissues, and some of those red blood cells that they do have will appear small or what they call hypochromic. When the patient has iron deficiency anemia, the manifestations they're going to exhibit will depending on how severe the anemia is. But some things to consider is that they likely will experience some paleness or pallor. Because the red blood cells are the ones that carry oxygen, generally these patients are tired more easily, so they experience fatigue and lethargy, even with what would be probably considered normal activity. They are more irritable. We do see, especially in children, the tendency for pica, which if you remember is eating non-edible items. Headaches can be a consequence of iron deficiency anemia, so can GI upset, and with that, the lack of appetite, and so essentially anorexia. So how do we manage it? Well, one important thing is that we want to identify if diet is the cause. If it's because of their not getting enough iron-rich or iron-fortified foods, then we just change what they're eating. But it could be something to do with how they're actually metabolizing the iron, and it could sometimes be that they're eating the right foods, but the body's not absorbing it because of something else that they're doing. Like, for example, we'll talk about it again in a minute, but milk or dairy products actually interfere with the absorption of iron. So if a child's taking in iron-rich foods, but they're pairing that with 8 ounces of milk, then it actually can like negate or void the body's ability to actually metabolize and utilize that iron. And then the other management option would be supplementation. And so that's us giving the patient iron in some other form, usually an oral medication that's available, especially for children in a liquid capacity. But obviously, if they can swallow pills, there's the choice of a tablet as well. And then in very severe cases, they could even need iron transfusions, like going and getting an IV and receiving iron transfused. So this would be probably what they consider the most common type of anemia, especially for children. And it usually is a nutritional or dietary deficiency when it's existing in kids. So the body requires iron for producing hemoglobin. Insufficient quantities of iron will limit the production of hemoglobin. So one way that you can evaluate whether a patient's iron content is sufficient is by getting their H&H, which is their hemoglobin and hematocrit. So we would expect that a patient who has iron deficiency anemia would also have a low hemoglobin. We talked about the red blood cells appearing small and hypochromic. Remember, hypochromic means there's less hemoglobin, so it's going to result in a paler color of the cells. They won't be as dark, and that's one way sometimes you can tell just by, looking at someone's blood draw at how thin and bright the blood is, that could actually be indicative of that iron deficiency. Some other symptoms that can occur as well, not necessarily as frequent or as much of a telltale for kids as it is for adults, would be things like spooning or the concave shape of the person's nails. They can have an unsteady gait or basically some dizziness and weakness in their ambulation. They can obviously suffer from shortness of breath, which makes sense thinking about the RBCs carrying our oxygen. They can also have an increased heart rate. So tachycardia can be a complication for anemia. Difficulty feeding, and then in some severe cases, even splenomegaly, which of course would be something that would need to be monitored closely. We do see that premature infants are the most susceptible to this, and that's because they've had less time in utero. So they weren't able to receive as much of the maternal stores as an infant that was full term or that was able to have a longer gestational age. Okay, and then you would benefit from reviewing what are some iron-rich sources, because this is something that, would make sense if we're talking about nursing interventions. We want to be able to educate and encourage whatever items would actually help to reverse this anemia in a child. So things like red meats, which are probably the easiest for the body to absorb. Some forms of fish like tuna and salmon. Eggs are actually high in iron. Beans, peas, those forms as well. Leafy green vegetables would be one. And then any kind of iron fortified item like a breakfast cereal typically has increased iron in it as well. There are some fruits that are high in iron, and tofu was another one. Okay, when talking about iron deficiency anemia and talking about it from a supplementation standpoint, we want to make sure that we're addressing what kinds of education do the children and really the parents need in terms of the supplemental iron. So what I'm going to be speaking to, some of this overlaps regardless of the form of iron that the patient would be receiving. But some of it, you have to, use common sense. But it depends on if we're talking about liquid form versus, say, a tablet. So something that is universal for iron administration is that it should be given with citrus or vitamin C enriched foods. That's going to help to increase absorption, while on the contrary, it should be avoided with milk or milk products. So vitamin C or citrus foods, other sources, is a good thing to pair iron administration with, but not at the same time that the child would be consuming milk or other milk products. It will likely result in some constipation or GI upset, so it's important to make sure that the person's taking in enough fiber and fluids, because fluids are going to also help to keep the stool soft and prevent dehydration. So one thing that may help to counteract some of those unwanted side effects would be that increased fiber and fluid intake. When it's the oral form, then it does have the tendency to stain the teeth. So the recommendation is that anytime a child's taking a liquid form of iron, that they do so through a straw versus, say, a medicine cup, because then it allows them to put the liquid behind the teeth. Or if it's being given with a syringe for a younger child, then you're pushing it, behind the teeth. You're trying not to just deliver it to the front of the mouth, because that can tend to stain the teeth. Another idea would be, as soon as they receive their liquid administration, going ahead and performing some oral hygiene on the child. For the same reason that we would increase fiber and fluids, we may have to administer stool softeners, since constipation is often a consequence. And it's also why they'll typically administer the medication in divided doses. So whatever the amount is that's appropriate for the child's age, instead of taking it once a day, they may take it twice a day, in the morning and in the evening. By separating the two, they're not taking as much at one time. They're hopefully reducing those unwanted side effects. Very important that it's measured precisely, just like any medication for pediatrics, but there is a such thing as, being overdosed or toxic amounts of it. And know that it's normal for iron consumption or supplementation to change the color of things like the child's stool and urine. Stool typically can become black or very dark color, and the urine can become very concentrated in appearance. So those changes are something to, educate on, to expect them, so that they're not worried by them. We talked about the iron-rich sources previously, but there's also a table in the textbook that you can reference for that. Let's see if there's anything else. I think that's it for that one. Okay, moving along. Okay, so that pretty much concludes what I needed to teach you about iron deficiency anemia. Remember to, reference what we've talked about in previous chapters, like in growth and development, those children who are more prone to it. We talked about it being the case with infants, especially preterm babies, but we also see it a lot in our toddlers. And our toddlers, it happens because of their picky eating and their food fads. So their tendency to only eat certain things or to graze more than consuming meals. So they'll tend to be, more likely to end up with iron deficiency anemia. And then again, in our adolescent population, especially our adolescent females. Adolescents in general could be because of their eating habits, more junk food than, nutritious food. Sometimes eating disorders can play a part in that. But for our females, also because they're starting their menstrual cycle. And when they have a menstrual cycle, they're losing blood. And so that blood deficit can also create that iron deficiency scenario for those kids. Okay, So next we're looking at sickle cell anemia and disease, which again should be familiar. This is the one where basically there's some abnormal shape to the hemoglobin. So what we see with these red blood cells is that they're like a donut shape. Well, what would normally be a donut shape becomes this crescent, elongated, thin, stretched sickle shape. So the RBCs are changing from their normal appearance of the donut shape to this crescent or moon sickle shape. This is a genetic mutation. So this information is found out on the child during their newborn screenings. You've learned about it, I would hope, with our newborn content and probably an OB by this point, but they're going to have what's called a PKU, and that is a specific panel of blood work that's checking for multiple things, including PKU. And one of those things is sickle cell. Are they a carrier, or do they even have the disease itself? So this information, this is chronic. This is not something that would spontaneously develop for the child. They would know this and have this from birth. It is a common thing, especially in certain ethnicities and populations of people. And the way in which it manifests has to do again with the abnormal appearance of the red blood cells. So again, being the cells that carry your oxygen, because there's some deformity to them, the patient's going to likely experience fatigue and weakness, pallor, that pale color. They could even end up jaundice with sickle cell. They also typically have pain, especially in their joints, because the blood flow is affected in those locations because of our abnormal configuration of these cells. Excuse me. They can experience mental status changes associated with hypoxia. They can have abdominal pain, and like we mentioned previously with iron deficiency anemia, splenomegaly is a possibility. These individuals are more likely to experience infections. They're typically more compromised because of the impact this disorder has on the spleen. And spleen is one of your organs meant to protect you from illness. And then they can also have enuresis as well. Some patients are pretty asymptomatic initially. Some have very few or very infrequent flare-ups of the disease manifestations. So they may be able to, be in control basically of having any of these manifestations for a time, and then they'll experience them kind of in exacerbations, a lot like an asthma patient might have. It can progress to what they call sickle cell crisis, which we'll talk about in a second. So these changes that are happening to the body systems associated with the sickling or the trapping of the red blood cells is resulting in the tissue hypoxia, so less oxygen at the tissue, further sickling, and then ultimately it can lead to areas of infarction where there's no circulation of oxygen there. Let's see what else. Of course, with our joint discomfort or pain, that's going to also affect their range of motion, their mobility. So you may see limitations in that when they're experiencing it. The enuresis, or the incontinence, the bedwetting, is also happening because of the kidneys that aren't able to concentrate the urine as effectively. So that is a possible complication that can occur with it. And just in general, as the person ages, they become more likely to experience multiple organ issues or multiple organ dysfunction. Okay, we talked about sickle cell crisis. Let's see. So the book actually refers to several different complications that you won't be tested on for purposes of my exam, but it's still good information to be aware of. And again, hopefully it's something you've seen previously in the curriculum, either with patho or with med-surg. But one of those complications is called vaso-occlusive crisis. So this is when the blood flow is obstructed, resulting in tissue death, basically hypoxia and ultimately necrosis. With this, the patient experiences a very painful episode of swelling to their soft tissue, and it usually involves the hands and feet. They call it a hand-foot syndrome. Another complication that can occur is acute chest syndrome. With this, the primary effect is the lungs, so the patient experiences chest pain, coughing, increased work of breathing, wheezing, fever is likely, and basically it's clumping of cells in the lungs that's creating this pulmonary infiltrate, if you will. And then another would be sequestration crisis. So sequestration crisis would be when the spleen is losing its function, and that's associated with it becoming enlarged. And so sometimes they have to have that, operation to remove. And then the final would be a stroke, which we know of as a cerebrovascular accident, or CVA, when the blood vessels in the brain are where there's blocking of circulation, and this can impair the neurological function. So these are all things that, we need to make sure that the family is aware of, and that we're taking the right precautions to try to decrease the risk of any of these complications. Okay, so what is that management going to look like? Well, again, prevention is probably the most important. We're instructing the family, the child, on what are the things that are likely to cause a sickling crisis or lead to an infection, so that we can try to minimize that. As the nurse caring for these children, we're going to make sure we're clustering our care. That's going to allow for rest periods for the patient and try to, prevent that fatigue and hypoxia occurrence. But we don't want them to be completely dependent on caregivers or even healthcare providers for their care. We still want to encourage them to do some activities themselves, which is going to help to, maintain muscle tone and help with growth and development. And in some cases, it might even require that they be treated by a physical therapist. We're going to control the pain they're experiencing, depending on what that pain looks like and where it's located, and the age of the patient will probably dictate what that management includes, but examples would be analgesics, distraction techniques, even other forms of complementary therapy. And then another would be hydroxyurea, which this is used to help with the reduction of painful crises. It's basically working by reducing the need for blood transfusions in these patients and helping to minimize the progression to a severe crisis. It's a cytotoxic medication. In some cases, they may ultimately need a splenectomy. We talked about the spleen enlargement being something that's associated with them. They may need stem cell transplantation. They may need blood transfusions. So these are all some management that goes beyond just the pain control. A lot of times when they're hospitalized, they're also going to be on oxygen, so they're going to get supplemental O2. We want to try to maintain hydration for these patients, and that will help ensure electrolyte balance. So they may require IV fluids if that's not able to happen orally. And then because of the infection risk, a lot of times they are going to be given antibiotics if they have an infection, but even sometimes in a prophylactic or preventative way. So like prophylactic penicillin, for example. And there's some good education points you'll want to look at that are in your textbook that you can find on page 496. Okay, so that first section, anemia. Now we're talking about our clotting disorders, which is a different type of blood cell. Instead of red blood cells, now we're going to be speaking to our platelets. So these disorders have to do with some kind of platelet related problem. Individuals do not bleed more easily than others, but they do have more difficulty with clot formation when bleeding occurs. So in this case, it's not that the patient's necessarily more at risk of having a bleed. It's that their bleeding is hard to interrupt or to cut off and create that clot formation. I don't know if that makes sense what I'm saying. So the examples that we're going to be looking at are hemophilia and von Willebrand disease. Now there are other diseases your textbook talks about, like DIC, ITP, HSP, but the ones that we're going to be looking at are just hemophilia and von Willebrand, which also happen to be ones that are associated with some kind of genetic factor, or they're a result of a genetic cause. So as the screen states, hemophilia is a deficiency in one of the clotting factors in your blood. This one that we know of the most common is hemophilia A, which is a deficiency in factor 8. But there are many other examples out there. So hemophilia is what we would consider an umbrella term. And then there are many different types. Like one of them is called the Christmas disease, but it's a different factor that the patient's deficient in. When we're talking about this particular disease for purposes of our exam, we're not going to get into the nitpicky types of it. I just want you to be aware that hemophilia is a broad term, and you really need to make sure that you're evaluating the patient for their individual or specific type of hemophilia. Some have more severe forms, some have more minor forms, some do not require factor replacement to function, some only need it in an emergency scenario, some need it to live. So it's really important that you do an evaluation of your patient and get to the bottom of what exactly does their hemophilia look like whenever you come in contact with a patient with this diagnosis. The other thing that's true of hemophilia, and I think it's going to be on a slide coming up, is that it is X-linked. So it's expressed in our males. Females can be a carrier for hemophilia, but they're not going to actually have or show the disease. It will only be true of our male individuals. And again, it is a genetic or hereditary bleeding disorder. Let's see what else. So one way that I had written in here to share with you kind of to understand what's going on in the body. When bleeding occurs, the vessels constrict in what we normally expect as a platelet plug to form, which is clotting. But when that factor is deficient, so whichever one of the factors that the child is deficient in for their type of hemophilia, the fibrin doesn't solidify, and that's what results in the continued bleeding. So these children don't need platelet transfusions, they need factor replacement. So when you're talking about what we're doing to manage them, we'll talk about that again in a little bit, but one of the things to remember is that, you know, even though it's a platelet-related disorder, it's not an actual platelet deficiency, it's a factor deficiency. So another thing I wrote in here is factor 8, which is again the most common hemophilia type that exists. It's probably, I think statistically, like 80% of persons with hemophilia have that form. Factor 8 is essential in activating factor X or 10, which is required for conversion of prothrombin to thrombin, so PT to T. So we have to make sure that, you know, we understand that sometimes one factor that's deficient may actually impact another factor's normalcy. Let's see what else. Okay, so what are the manifestations? Well, that I mentioned previously, it can range from person to person, from mild to severe. A lot of times we'll see it be more severe early on in the child's life, and that it actually improves with time or with age. So you don't necessarily outgrow it, but it can become such that it's not a concern, and they don't really need many different management protocols than somebody who doesn't have hemophilia. So spontaneous bleeding is what it's going to seem like. Now, we talked about it again, like they're not just going to be, sitting in a chair and then just start bleeding. I don't think, not any more so than anybody else would, for that matter. But it's going to seem like it's more extensive because it's taking less injury or trauma to create that bleeding, or that what would normally clot easily isn't. Bleeding into joint cavities, which is termed hemarthrosis. Deep tissue hemorrhage, so we could even have hemorrhaging or bleeding that we can't see, that it's deeper in the body. These kids are more prone to nosebleeds. We may even notice just in general they bruise much easier. So it could be a very minor, like I said, injury, but they're going to end up with, a pretty decent bruise from that. And then also bleeding in the urine, hematuria. So the management, of course, ideally prevention of any kind of injury or bleeding episode would be our first line. But when that can't happen, or when that doesn't happen, our measurements or efforts from there are trying to stop the bleeding. So pressure application would be something. Cold application, because that's going to help with the vessel constriction. So we're going to hopefully, minimize the amount of bleeding that happens when we apply cold to the body. It could even be that they need clotting factor. So depending again on how severe it is, that might be an option, is to actually give them clotting factor. Education and support, of course, is crucial. With these children, depending on the severity, it may limit the sports they can play in school. It may, limit the activities that they can participate in. So there has to be some element of support for them. And it really is best recommended that these individuals wear a medical alert bracelet, something that would identify them as having this bleeding disorder in the event that they can't communicate that. We talked about that it's going to be present from birth, but it's very normal for some children to not even express or manifest any symptoms until they get a little bit older, usually 6 months to a year, which is when they're starting to do walking and climbing and crawling, and so the tendency for injury increases. Whereas as a baby, we wouldn't expect them to easily be injured. But there are some ways in which we typically will see it early on. Remember, it's males that are affected, so one thing would be with circumcision. They may go for a routine circ in the hospital when they're first born or a few weeks after, and what normally would have stopped bleeding within a few minutes ends up becoming this, prolonged bleeding episode. Another would be with immunization. So when they're getting vaccines, the areas where they're being vaccinated, when they receive their intramuscular vaccinations, what normally would stop bleeding right away and a Band-Aid would suffice, needs, a pressure dressing or, some length of time that you're actually applying pressure to get the blood to stop. Okay, von Willebrand disease, though similar to hemophilia, it differs in a few ways. One is that it's usually milder, so there's not as severe of cases of this as there are of hemophilia, but it can still be true of an individual. It's autosomal dominant, and it can be expressed in males and females. So it's not just X-linked, so we will see both genders that manifest it. Now, von Willebrand disease is lacking in a particular factor. That factor is known as von Willebrand factor, or VWF for short. So that's the deficiency that this individual has. So it's classified differently than hemophilia. The manifestations are similar, usually, though not so severe. So it's going to be more of your bruising easily and your having nosebleeds, or just with injuries taking a longer time to be able to stop the bleeding. Let's see. How do we manage it? One way would be administering clotting factor, and this one specifically would be the von Willebrand factor. Another would be desmopressin nasal spray. Desmopressin can actually be administered multiple forms, intranasal, intravenous, sub-Q, which is actually not as common. But with that, it's going to release factors 8 and VWF into the bloodstream. So it's going to help to replace that deficiency of the clotting factors. It's an antidiuretic hormone, so you have to monitor fluid balance with this patient. So anytime that they're taking antidiuretic, we want to make sure that their fluid balance is maintained. And then additionally would be responding to the bleeding with, pressure dressings and cold application if we can't prevent it to begin with. So epistaxis is mentioned on the slide, or nosebleeds. The textbook doesn't say much about that, so I actually found it in the ATI book, and for the 11th edition, it's on page 125. So I would suggest reviewing that information since it doesn't go in depth on the PowerPoint. But there's things like, we want to try to make sure that the child remains calm. We want to make sure that the position the child takes is to sit up and tilt their head forward. That's going to keep them from swallowing the blood or potentially aspirating the blood. I don't know why, but for some reason our tendency naturally when we start bleeding from the face, especially the nose, would be to stick our heads up, and apply some pressure. Well, that's actually just going to aid in the swallowing of it. So what we would recommend is for the person to apply pressure to the lower nose with the thumb and forefinger and lean the head forward. And this is to be done until it stops, but it could be as long as 10 minutes to be able to ensure the bleeding has ceased. If needed, it could even require packing, like putting cotton or tissue in the nose to help absorb the bleeding. When they're bleeding from their nose, we obviously want to encourage the child to breathe through their mouth. And sometimes they'll even do ice application just across the bridge of the nose because, again, it's going to help with that vasoconstriction. So just some things you might want to look back at, but in the ATI textbook. Okay, our immune disorders that we're going to look at, actually, it's just one. It's HIV, which has AIDS associated with it. So there are others that are in the chapter. There are others that are very common in pediatrics, but my understanding is they have been discussed with you in depth enough in other courses in the curriculum that we don't have to spend time on them in our course. So it's a great refresher. You definitely would benefit from looking over this information, especially before proctored ATI and obviously NCLEX. But for testing purposes for this class, the only one you will be tested on is HIV and AIDS. Okay, so HIV, we know rapidly invades the central nervous system in infants and kids, and it can lead to, progressive encephalopathy. So one thing to know that we might see in children that differs from your adult population is developmental delays or, disabilities. So we might notice that more often in kids when there's that CNS impact. So this can be acquired two ways, vertically or horizontally. Vertically means you acquire it through birth, like in utero, or even from breast milk. Horizontally means you're acquiring it from some secondary contact, like non-sterile needles or sexual activity. So talking about children, what we would expect that most of our kids have is the vertical acquisition, which means from utero or birth, breast milk, those things. There was a huge concern with any kind of blood transfusion that a person was going to contract HIV, but now due to the way that the screening process is done and the advancements in technology, it's actually very rare for somebody to contract HIV from a blood transfusion. There is no cure for HIV, so it's something that requires lifelong medical management, but never can actually be cured. And what's happening from a pathophysiological standpoint is that this infection is actually altering the cell function in the body, T cells, B cells, and the NK cells, which is going to compromise immune function for the person. So these individuals are going to stay sick and get sick very easily. So what does it look like as far as manifestations? Especially in our kids, one thing we'll note is failure to thrive. And we talked about that previously. Remember, that is when the child is less than the 5th percentile for height and weight. So basically, they're demonstrating a lack of development in all areas. And usually, in addition to their physical growth, it's also going to mean there's some cognitive delays for that patient. Recurrent infection, even with just what we would consider simple or ordinary organisms. So things that would normally not create a severe infection in a person can cause a very severe infection in a child that has HIV. Adventitious breath sounds, so any kind of abnormal breath sounds. Enlarged lymph nodes could also result in enlargement of the liver or spleen. Opportunistic infections, I didn't realize that recurrent infections is on there, but again, it can just be these very minimal exposures that result in some severe illness for the patient. They can exhibit chronic and recurrent diarrhea, recurrent or even persistent fever, again because of their immune compromise. Delays growth and developmentally, and another would be thrush, which is a yeast infection. So they get either frequent episodes of thrush or a persistent form, like one that's not responsive to treatment, doesn't seem to be improving with management. The other or the main management for these individuals is this highly active antiretroviral therapy, or HAART for short. Just like in the adult patient, it's just different volumes or concentrations of the medications for the pediatric patient. Some patients can handle or only require, single drug therapy, but most require a combination of meds for lifetime treatment. What are some stressors for HIV infection, or what are going to escalate the infection or result in more complications for the person? And so obviously, we know things like the financial difficulties that come with it. They're going to spend a lot of time in and out of the hospital, or, possibly missing school. So that is something that needs to be considered. If parents are having to take off of work to be with their hospitalized or sick child, that's going to put a strain on them as a family. The fact that it's not curable, of course, the stigma associated with it, it's obviously something that they want to probably keep confidential, and in some regards that's feasible, but not always. And so knowing that and providing some support groups and materials for that purpose would be important. And just knowing that for this child, they're going to continually have medical problems. They're going to probably require many specialists. They will likely be hospitalized often. So, for them, there's a good chance that there's going to be a very abnormal, development or interruptions to the normal flow. Our goals for nursing care, obviously avoiding infection, making sure there's compliance with the meds, making sure the patient stays hydrated and has adequate nutrition. We want to for sure address any pain issues with comfort measures and management for that. Education as needed, and additional and ongoing psychosocial support as well. Okay, that is your part 1. So there's actually going to be a different video for part 2.